Good day and welcome to ISICEM and welcome to all of you in the audience. My name is Paul Wischmeyer and I'm a professor of anesthesiology and surgery at Duke University School of Medicine. And I'm really excited to be here today to talk to you about new research we have done looking at nutrition and metabolism and the metabolic needs of COVID-19 patients, and perhaps indicating that we need to feed a little less early and feed more late, but I will tell you more about it. These are what I would like to call alignments of interest. My research is sponsored by government, industry, and foundation work that I think we're all aligned in trying to improve the care of patients and provide the best care for all our patients. So I think we've all learned by now that the physiology and course of this new pandemic SARS-CoV-2 disease is one that progresses from an initial viral response phase to patients who at times go on to the ICU and have a marked hyperinflammatory response phase. And the question is, does this hyperinflammatory response phase lead to some of the long-term effects on metabolism and strength and long COVID symptoms that we've seen? So this is a recent publication in one of the JAMA journals that shows that 53% of post-COVID patients who weren't even in the ICU have significant fatigue and poor quality of life at 60 days after discharge on follow-up. So again, these patients are having persistent symptoms. And in some of the research we're doing, we've hypothesized that there's a persistent hypermetabolic and hypercatabolic phenotype in COVID-19 that is driven by this hyperinflammation and also other immune derangement that leads to this hypermetabolism, mitochondrial dysfunction, and substrate utilization changes. And this leads to the muscle wasting and cardiac dysfunction that these patients have, and ultimately to poor clinical outcomes, but just as important, poor long-term outcomes in this long-term fatigue. And this can be modified, of course, by nutrition, rehabilitation, and by the drugs we give to our patients. And we're doing research now studying this. And so the key message, of course, is we have to take responsibility not just for the outcomes in the ICU with COVID-19, but what happens after as well. And we all know our goal is to create survivors of our patients, survivors that go back to a good quality of life, not victims who were perhaps lifelong impaired by their disease, whether it's COVID-19 or other ICU illness. Ultimately, we want our patients to walk down the street again with the people they love and hold the grandchildren of the people they love and their families and be with them again. And that's difficult. We have a real challenge in the COVID-19 patient. Many of you would agree these are the sickest patients we've cared for in many years in most cases. And so are we going to be able to create survivors of these patients, or will many turn out victims, as already we have an epidemic in post-ICU weakness or PICS, with 60 to 80% of our prolonged ventilation patients getting impaired. And we believe, or I fear, that COVID-19 will make this worse. Why are we losing this quality of life war? Well, we know that in routine ICU or major surgery patients, a kilogram of lean body mass a day can occur because of this persistent hypermetabolism, hypercatabolism that we already know can persist for months to years. A burn child will remain catabolic for 2 years after they leave the ICU. We're not evolved to survive these illnesses as humans. And COVID-19, we hypothesize, may be worse because of its prolonged inflammatory phase. So we need to be better. And to do that, we're going to need to combine nutrition, exercise, and perhaps some elite athlete training, which I'll talk about in one of my future lectures on ICU rehab. But these patients are going to be challenging, and how do we know how much to feed them? And so I think the key message is one size is not going to fit all, and we need to personalize how we feed, giving the right dose to the right patient at the right time, and we need to be able to measure this. So how do we put this into practice, and what are our guidelines saying now, and what can we learn from the new data that we've been working on? Well, our guidelines, at least from, say, ASPEN and SECM, would say that we should start nutrition early, 24 to 36 hours of ICU admission, and that we should feed different amounts in different phases of illness. And in the acute phase, they recommend a slow hypercaloric or trophic ramp up of 15 to 20 kcals on actual body weight, and then deliver enough protein. And the reason for this is we know that in well-nourished patients, the body can break down muscle to generate the calories it needs, 50 to 70% of the calories it needs, the non-protein calories, and so perhaps we don't need a lot of extra non-protein calories early. And Pierre Singer's shown us the best survival early in ICU care, maybe when we give 70% of resting energy expenditure. And so, but in COVID-19, we have a whole new disease, and so we need to be measuring this. We need to know what's actually happening. And the way to do that, of course, is indirect calorimetry. The ISICEM guidelines recommend we all should have an indirect calorimetry, and we should be using it in COVID disease. And this is the ISICEM guidelines recommending indirect calorimetry being done in COVID disease. And again, there seems to be signals of improved outcomes when indirect calorimetry is used in research studies. Perhaps improved mortality even is where the signal is trending. And so the good news is, until recently, it's been hard to do this, but now we have a new indirect calorimeter, a new generation built by physicians across the world, led by Claude Bouchard and Jan Wernerman, names we all know, that I had the honor of joining as the only US site, so that we had a truly international group along with in Asia. And we have a new validation study that was just published this year. And this new device is a whole new world of indirect calorimetry. It's accurate, it works rapidly, it's a touch screen, it self-calibrates, it's a whole new device, and it measures in 10 to 15 minutes, and it can go up to an FiO2 of 70%. We've used it in PEEPs of up to 16. It seems to be accurate on CVVH. It's a whole new world of indirect calorimetries. So we proposed a study at the beginning of COVID. We started this in April, where we were going to measure longitudinal energy expenditure and other metabolic physiologies to describe the phenotype metabolically of COVID-19. And this data has been accepted for publication in critical care, and I hope it will be out any day, if not perhaps before this lecture actually shows. So again, no data exists, and so we need to get this data to understand what the metabolic response to COVID-19 is in the ICU. So we made a lot of measurements. We're doing metabolic carts, muscle ultrasounds, BIA, and echoes every 3 days in patients from ICU admission to hospital discharge, so we can get this data. This has almost not been done in many other studies. This is a unique study, we thought. So first, are COVID-19 patients hypermetabolic in the acute phase? Well, I will show you that they're not. So again, this is a patient with COVID-19. This is a mid-50s long-term care patient who came to us. Many of our patients are coming from assisted living and nursing homes. She's day 2 of her disease. She's spontaneously breathing on the vent. She's not paralyzed. And her predicted energy needs are about 15 kcals per kilo, or 70% of what Harris Benedict would predict. So she's a hypometabolic patient in that first week. She's not hypermetabolic. This is another patient. This is a patient who weighs about 60 kilos. He's about 49 years old. And he is showing on day 4, 78% of predicted of what our equations would predict. So he's also hypometabolic. Our brilliant ICU dietitian at Duke, Leslie Murray, had him fed right on the nose at 1440. And this patient was prone and paralyzed when this was done, and he was on a PEEP of 12. But what about as patients move into the recovery phase? This is the same 49-year-old patient, 48-year-old patient. He's now day 12, and he's now being underfed still at 1440, but he's measuring 2436. 35 kcals per kilo on measured energy expenditure. And again, he was paralyzed when this was done, so we needed to adjust his feeding. Just a few days later, he's now measuring out at 3,000 calories almost per day, 200% of predicted by our equations. He was febrile at this time. He was febrile most all the day, as many of these patients are, but he's measuring out at 44 kcals per kilo. But he was febrile 80% of the day. So we had to again adjust his feeding and account for that. This is the patient. He's a little bit better now, day 18. And again, he's still measuring out at 28 kcals per kilo or above predicted, but his needs are changing dramatically every few days based on his clinical state and other parameters. But then the patient on day 23 jumps back up. And again, he's showing a very high metabolic rate, needing 35 kcals per kilo. Again, these patients look like the burn patients I used to measure when I was a burn ICU physician. And he needs a significant caloric delivery to meet these metabolic needs. And so this is the summary of the data in the first 22 patients out to day 21 from our study that will be in critical care. The average age was about 58. We had patients from 30 to 88. They were about half male, more than half African American or Black, and more than half were obese. Our average BMI was 31. And again, obesity seems to be a major risk factor for adverse outcomes and ICU stays in COVID-19. So you can see 12 of the patients had high BMIs. They averaged about 14 days to 18 days of ventilation time during the 21-day study period. Their mortality in the study was 14%. Their total hospital mortality was 22%. We've done a lot better job saving these patients. But again, our measured metabolic rates were exceedingly high as 3,000 kcals per kilo after the first week. In the first week, their caloric needs were quite low, 1,500 kcals per kilo, and then they ramped up over the next 2 weeks and continued perhaps to ramp up after that. You could say they needed almost 30 kcals per kilo. And in their obese patients, that stayed the same. In fact, obese patients needed more calories per kilo on adjusted body weight and actual body weight than any of our guidelines suggest. And these patients are also very hard to feed. You can see we are underfeeding them much of the time. So these are the actual measured respiratory RQ ratios, VO2 and VCO2. This is John Whittle. He's an ICU physician. Some of you know, he trained with Mervyn Singer. He was the first author of this paper and has been working with me for many years on these kinds of questions. This is the average measured resting expenditure, in all patients on actual body weight. You can see a great deal of variability across time. These are the non-obese patients. This is an actual body weight. And again, you can see Harris-Benedict predicted there at the bottom. And so these patients had much lower needs early and then much larger needs late with a lot of variability. These are the obese patients. The Aspen guideline recommended is in those green lines. So again, all these patients were above Aspen predicted needs on actual adjusted body weight. They were very hypermetabolic, and this persisted beyond day 21. I can tell you it persists beyond day 28 in some of our data. So again, these are the obese patients. These are comparing obese and non-obese, significant elevations throughout stay, some variances, and that's the Harris-Benedict predicted. This is Krista Haynes. She's one of our other ICU physicians at Duke. She graphed this data showing the variability across the days and the need for all of us to have metabolic carts because there's no way we could predict these variations in our patients. And then this is the green dotted line here shows the feeding patients were getting. They were underfed throughout their care. And again, so they were very difficult to feed. The actual nutrition delivery there is in green. The predicted there is in orange. So this is the clinical data. We proned about 10 to 12% of these patients. That didn't really change over the 21-day period. About the same percentage were paralyzed throughout the period, and the SOFA scores were about the same week to week. You can see there's a number of people remaining in the study. Proning went down some after the first week, but then came back up throughout the study, and there wasn't much statistical difference. These are the SOFA scores throughout care. They're about the same. And so our initial data shows that these patients are normometabolic or even hypometabolic in the first week, and then become quite hypermetabolic after the first week. So our initial data shows that feeding about 20 kcals per kilo on actual for normal BMI patients and more, 20 kcals per kilo on adjusted weight, not more, but 20 kcals per kilo adjusted weight in obese are close to measured. And we again suggest 70% of 20 kcals per kilo and ramping up the feeding. So the other things we found was older patients seem to need less, obese patients seem to need more, and fever significantly increases that need. Now, hypermetabolism doesn't appear to be related to the severity of organ failure or severity of disease that we can measure, and it doesn't seem to have much relationship to paralysis or sedation. And that's not surprising, actually, because Arthur Van Zanten has published that there's very little effective paralysis on measured resting energy expenditure, about 6%. So that's not surprising, very minimal effective paralysis. So again, this is what our actual measures are drawn on our traditional caloric needs based on what COVID-19 patients showed in our study. We've now enrolled up to 36 patients, and so we'll continue to have more data. Again, protein needs to be part of this. We have lower mortalities with better protein delivery. Our protein curves look like this. So we think protein's key. And so as I close, how to address nutrition, again, we think this is a hypermetabolic state that persists longer than in most critical care diseases, driven by inflammation. And I think if we're going to create survivors and not victims of our patients, we have to personalize our feeding. We have to do better. We have to use metabolic carts. We have to be using more supplemental parenteral nutrition for our patients because they're wildly underfed because of the way COVID affects the gut. And we can guide this with our metabolic carts. And there's lots of things we can do that I've talked about throughout my lectures to prevent COVID and treat COVID throughout their stays. These are my recommendations. Ramp up your protein and calories early, less at the beginning, more later, and then you need to get to goal and realize these patients will stay hypermetabolic a very long time. My hope is with good feeding, then we can take patients that look like this, have them look like this, and have them leave the ICU like this, or at least like this. And with that, thank you for listening. I'm happy to take your questions and feel free to reach out to me with any data that you'd like to have and any questions at any time. Thank you.